Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐞. I am the general medicine educator. So in this particular session, I'll be doing the quick revision of the entire hepatobiliary system. So in this session, I'll be discussing about the ascites, portal hypertension, and as well as the viral hepatitis, right? Now you take this ascites, what exactly this mean? It is the scenario where there is excessive accumulation of the fluid in the peritoneal cavity. And normally in the peritoneal cavity, do you have the presence of any fluid? No, right? In the peritoneal cavity, you don't have the presence of any fluid. Either you take in males or females, there is no fluid in the peritoneal cavity. The physiological fluid that can appear in the female is during mid-ovulatory cycle, okay? So during the mid-ovulatory cycle in females, there can be around 10 to 20 ml of the fluid that can be there within the peritoneal cavity, which is normal, okay? Now, and at the same time, let me also just discuss what will be the normal quantity of the fluid in the other serous cavities apart from the peritoneal cavity. You take the normal quantity of the pleural fluid. Normal quantity of the pleural fluid in the pleural space, this is around 5 to 15 ml. And what is the use of the fluid in the pleural space? It will reduce the friction between the parietal pleura and visceral pleura, and it will act as the shock absorber to the external injuries. That is the use of the fluid which is there within the pleural space, right? And if there is pleural effusion, what exactly will be the investigation of choice is the CT chest will detect even the minimal quantity of the fluid that is accumulated within the pleural space. And at the same time, the other important serous cavity is the pericardial space. So what is the normal quantity of the pericardial fluid in the pericardial space? So that is around 20 to 50 ml, right? So that is around 20 to 50 ml. And what is the use of the fluid in this pericardial space? Again, the same thing. It will reduce the friction between the parietal and as well as visceral pericardium, and this particular fluid in the pericardial space will act as a shock absorber from the external injuries. And if there is like pericardial effusion, what exactly is the investigation of choice is the two-dimensional echocardiography, right? Now, let us discuss about this ascites. Now, the minimal quantity of the fluid, if it is accumulated within the peritoneal cavity, how is that it can be detected, right? We have an important sign called as the Poodle sign. I'll show you how do you demonstrate that. The Poodle sign can detect the quantity of the fluid which is accumulated within the peritoneal cavity if it is around 100 ml. So 100 ml of the fluid accumulation in the peritoneal cavity is called ascites, and that can be detected by what is called Poodle sign, right? And we have one more important examination methodology that is called as the shifting dullness. Okay, so if you take this shifting dullness is that which can detect the quantity of the fluid in the peritoneal cavity around 500 ml, okay? And we have one more methodology by which you can detect the fluid in the peritoneal cavity if it is around 1500 ml, okay? So we do what is called as the fluid thrill. So fluid thrill will be positive when the quantity of the fluid in the peritoneal cavity is around 1500 ml. So 100 ml can be detected by Poodle sign, 500 ml can be detected by shifting dullness, and 1500 ml can be detected by what is called as the fluid thrill. Now let me show you the images of these. Right. So you see this is the Poodle sign. So Poodle sign, it can detect how much ml? That is around 100 ml within the peritoneal cavity. So you should make the individual to lie down in the in the knee elbow position, right? You should make the individual to lie down in the knee elbow position, and the fluid gets accumulated within the central part of the abdomen, and you need to do the percussion. So when you do a percussion, the flanks will be tympanic note, whereas the central part of the abdomen, it will be dull note. That is how the Poodle sign will be positive. And this is how you will demonstrate the shifting dullness. So initially you need to do the percussion in supine position. So in the supine position, when you do a percussion, the central part of the abdomen, it will be like tympanic note, and the flanks, this will be of dull note. right? Flanks will be of dull note. Okay, now this will be, and after that what is that you need to do? You need to make the individual to lie down in the lateral position, either in the left lateral or right lateral. So the dullness which was there in one particular flank, this will be tympanic, and only on one side of the flank you will have the dull note. This is what is nothing but your shifting dullness, and the shifting dullness will be positive when the quantity of the fluid in the peritoneal cavity is around 500 ml, right? Then next is the elicitation of the fluid thrill. So this will be positive, like when the quantity of the fluid in the peritoneal cavity is around 1500 ml, right? Where this requires two examiners. One of the examiner has to place the hand in the central part of the abdomen, and the other examiner has to tap over one flank, and he will feel that particular wave of thrill or the tap on the other hand, right, on the opposite side. So this is how you will demonstrate the fluid thrill, right? This is about the quantity of the fluid and as well as the various demonstration. And on examination in patients with ascites, one of the very important finding that you will have is the umbilicus will be everted. So you will have the everted umbilicus in patients with the ascites. That is a very important characteristic finding. The other important finding is, for suppose, if the ascites, if it is due to cirrhosis of liver, along with ascites, what is that you will notice is the superficial veins of the anterior abdominal wall, right? The superficial veins over the anterior abdominal wall, they become more prominent. Right? They become more prominent. Okay, that is what you will observe in case of cirrhosis of liver. And the problem with the ascites is that whenever there is excessive accumulation of the fluid in the peritoneal cavity, the excess fluid which is accumulated within the peritoneal cavity, it will push the diaphragm up, and it will cause the compression of the lung parenchyma, resulting in the respiratory distress, right? Resulting in the development of the respiratory distress. Okay, and respiratory distress occurs mainly whenever there is tense ascites. Now what do you understand by this word tense ascites? Tense ascites is that the fluid which is accumulated within the peritoneal cavity, it is like completely packed, and in case of tense ascites, the fluid thrill will be absent, right? Fluid thrill will be absent, and here the quantity of the fluid which is accumulated in tense ascites, it will be more than 2 liters within the peritoneal cavity. And tense ascites, it is an important emergency, and these patients with tense ascites, you need to do immediate abdominal paracentesis. So you need to tap the fluid from the peritoneal cavity immediately. Otherwise, the individual can develop what is called abdominal compartment syndrome. Okay, so the complication that can be observed in tense ascites is development of the abdominal compartment syndrome. So in case of the abdominal compartment syndrome, right, in case of the abdominal compartment syndrome, like what is the problem that can be anticipated is the vessels within the visceral organs, they get completely squeezed, and the individual can develop the gangrene of the visceral organs. So that is what can be seen in case of the abdominal compartment syndrome. Okay, now in case of the abdominal compartment syndrome, and you know what will happen to the intra-abdominal pressure? So the intra-abdominal pressure is increased, right? And to what extent the intra-abdominal pressure will be increased in abdominal compartment syndrome is the pressure will be increased to more than 25 millimeters of mercury, and this we call it as intra-abdominal hypertension, right? So this we call it as intra-abdominal hypertension, right? Now what is the normal intra-abdominal pressure? The normal intra-abdominal pressure, this is around 0 to 5 millimeters of mercury, right? The normal intra-abdominal pressure is around 0 to 5 millimeters of mercury. So that is about the various ways by which you can demonstrate the ascites. Now at the same time, you need to be very much aware of what are the various etiologies causing ascites. Now the etiologies causing ascites, they have been classified based on one important parameter called as SAAG. Now what do you understand by this terminology called SAAG? that is serum albumin or serum ascites or serum and ascitic fluid albumin gradient. Okay, so this is what you mean by this word SAAG, right? That means the quantity of the albumin in the serum and the quantity of the albumin within the ascitic fluid. Both of these you need to measure and you need to take the difference of this. That is what is called as SAAG. Okay, that is serum ascites albumin gradient. Now, if this particular SAAG, if the value of this particular SAAG, if it is more than 1.1 gram per deciliter, that is suggestive that the ascites, it is due to portal hypertension. Right? And if the value of the SAAG, if it is less than 1.1 gram per deciliter, then the ascites is not due to the portal hypertension. Okay, right. Now, what are the various causes where you have the SAAG value more than 1.1 causing the ascites? All right, that is observed in very important condition, that is the cirrhosis of liver, right? Then BCS. What do you mean by the word BCS? That is 𝗫𝐷𝐼𝐻 syndrome. Now, in case of 𝗫𝐷𝐼𝐻 syndrome, what exactly happens? It is the hepatic vein thrombosis. Okay. Then the other conditions, wherever there is liver metastasis, where massive liver mets, then in patients with the congestive heart failure, in patients with the sinusoidal obstruction. Sinusoids are what? The sinusoids are observed in the liver, right? If there is any sinusoidal obstruction, even that can cause the development of ascites, and where the SAAG value will be more than 1.1. And the conditions where you have ascites with SAAG value less than 1.1, that is observed in cases of the nephrotic syndrome, which is characterized by the albuminuria, right? And any condition wherever there is bile leak, right? The condition wherever there is leakage of the bile. Then followed by that in case of the tuberculosis, then followed by that in case of the pancreatitis, right? Then followed by that in case of the peritoneal carcinomatosis. Right, peritoneal carcinomatosis. Okay, so these are all the conditions where you have the SAAG value being less than 1.1, right? And these are all the conditions where the SAAG value is more than 1.1. These are all the etiologies, right? Then how is that you will treat the patients with the ascites? So in the treatment of ascites, one of the very important part of the treatment, or the first line treatment, is the salt restricted diet. Right, it should be salt restricted diet, right? The sodium quantity in the diet should be less so that the quantity of the fluid will be reduced. And how is that you will flush out the fluid which is present in excess quantity in the peritoneal cavity? That is by giving the diuretics. And what are the diuretics that you need to supplement in these individuals is, you need to give spironolactone, right? You need to give spironolactone and then the furosemide. Right, spironolactone and as well as the furosemide. So spironolactone is what? It is an aldosterone antagonist, and furosemide, it is a loop diuretic. Now, what is the dosage with which you need to start this spironolactone is, you need to start at a dosage of 50 to 100 milligrams, right? And the furosemide, you need to start around 20 to 40 milligrams. And what is the maximum dose that you can give for the spironolactone? The spironolactone, the maximum dose that can be increased is up to 400 milligrams, and the maximum dose of the furosemide that can be increased is up to 160 milligrams. Okay, that is a maximum dose of these diuretics. Now, why is that you need to step up? You need to step up based on two important parameters. That is, you need to monitor the weight of the individual, and you need to monitor the abdominal girth of the individual. Right, you need to monitor weight, and as well as you need to monitor the abdominal girth. So if the weight is reducing and if the abdominal girth is reducing, don't increase the dose. But if these two parameters are not decreasing, like if the weight of the individual is not decreasing and abdominal girth is not decreasing, then in such case you need to step up the dose and the maximum dose should be given. Right now, in refractory ascites, what do you mean by refractory ascites? That means after medical treatment, the ascites, if it is occurring again, then what are the drugs that can be given? Now, one important point is regarding the spironolactone. Spironolactone, it is associated with very important adverse effect, that is nothing but the gynecomastia. Now, those individuals who are developing gynecomastia, you need to give alternative aldosterone antagonist. What is that alternative aldosterone antagonist that you need to give is, you need to give amiloride. Right? You need to give amiloride instead of the spironolactone, right? Or you can also give eplerenone. You can also give eplerenone, okay? So, and yeah, in refractory cases, one of the drug which is important is the midodrine. So, midodrine is what? It is a vasoconstrictor and that can be given. So, it is an alpha-1 agonist. Midodrine, it is an alpha-1 agonist. Now, what this midodrine will cause? Midodrine, it will cause the constriction of the splanchnic artery, right? So, whenever there is constriction of the splanchnic vessels, the quantity of the fluid which is entering into the peritoneal vessels will be reduced, and thereby the fluid which is exuding into the peritoneal cavity will be reduced. Okay, so that is the advantage of this particular midodrine, right? And in spite of maximum doses of all these drugs, if the ascites is still there, then you need to do what is called abdominal paracentesis should be done, right? Abdominal paracentesis should be done, right? That is large volume paracentesis. Or now, in spite of doing paracentesis, if there is like recurrent, repeated development of ascites in spite of doing this paracentesis, then you need to do one important procedure that is called TIPS. Now, what do you understand by this word TIPS? TIPS stands for transjugular intrahepatic portosystemic shunt, right? Transjugular intrahepatic portosystemic shunt. This is what is called as the TIPS, okay, right? And when you do a TIPS, the chances of the ascites will come down because you're bypassing, right? You are connecting the portal vein directly to the inferior vena cava. You are bypassing the pathway. Okay, so that is about your treatment in case of refractory conditions. And whenever you are doing this large volume paracentesis means what? You will take up to 5 liters of the peritoneal fluid from the peritoneal cavity. And whenever you are doing large volume paracentesis, at the same time, you need to give infusion of the albumin. You need to give the albumin infusion. Why? Because this albumin infusion will raise the oncotic pressure within the vessel, and that will cause the mobilization of the fluid back into the intravascular space. And that is the reason why you need to give albumin whenever you are doing this large volume paracentesis. Okay. And the TIPS, it is very much superior than compared to that of the abdominal paracentesis. Okay. So this is about the treatment. And now, depending upon the abnormal constituents or depending upon the etiology, the color of the ascitic fluid can change. Like for example, what is that particular condition where you have a black color ascitic fluid? Black color ascitic fluid, it is observed in case of the pancreatic necrosis, right? It is observed in the pancreatic necrosis, and this pancreatic necrosis, this is due to hemorrhagic pancreatitis. Right, this is due to hemorrhagic pancreatitis. Okay, so that is what is nothing but your condition where you will have black color ascitic fluid. And what will be the SAAG value here? The SAAG value will be less than 1.1 grams per deciliter. Okay, and in case of pancreatic necrosis, in the peritoneal cavity, even the amylase levels are also increased. Amylase levels are also increased. Now, that is one black color. The other condition is, right, the condition where you have the presence of dark brown ascitic fluid. Dark brown ascitic fluid that is observed in biliary tract perforation. Right, that is observed in the biliary tract perforation. In biliary tract perforation, you will have dark brown ascitic fluid. And the condition where you have the presence of the chylous ascites. Chylous ascites, it refers to the turbid milky or creamy peritoneal fluid, right? And where do you have this chylous ascites? That is in the presence of rupture to the thoracic duct, right? Rupture to the thoracic duct, okay, or the presence of the intestinal lymph. And what does this chylous ascitic fluid contain? The chylous ascitic fluid contain the excess triglycerides. It contains the excess amount of the triglycerides, okay, and it also contains the excess amount of the fat globules, right? It also contains the excess amount of the fat globules. And what are the various causes? That is your rupture of the thoracic duct, tumor, tuberculosis, filariasis, and even the nephrotic syndrome. And one quick discussion is about the paracentesis, okay. Now, where exactly will be the site where you will do the abdominal paracentesis? Let me show you the image. Right. What are the preferable sites of doing the abdominal paracentesis? Okay. So first of all, what should be the position of the individual? The either completely supine position, right? The head end, it is slightly elevated, okay, so that the fluid, it tends to move down into the flanks so that you can easily tap and take out the fluid, right? Now, which side is preferred? There are two sides where you can do the abdominal paracentesis, and whenever you are inserting the needle, you have to insert the needle with an angulation of the 45 degrees. And what is the technique that we follow? That is Z tracking. Now, what do you understand by this Z tracking? Z tracking is that you don't pierce the needle exactly perpendicular to the surface of the abdomen and take out the fluid. No. By doing that, what is that you are doing is, you are creating the two rents. You are creating two punctures. One is over the abdominal wall and one is over the peritoneal cavity. So whenever you take out the needle, the fluid will be leaking out from the peritoneal cavity to that of the puncture which is there over the surface of the abdomen. So to avoid that, what you need to do is, you need to give little pressure over the abdominal wall and push the abdominal wall slightly downwards. Okay, that is, the skin has to be pushed slightly downwards. Then you insert the needle, right? Then you need to again change the angle of the needle, right? Change the angle of the needle and again change the angle of needle. There you will be reaching the peritoneal cavity. So this is what is called Z tracking. By doing that, what is the advantage? Now the puncture what you have created over the surface of the abdomen and the puncture over the peritoneal cavity, they are not in the same line. So even though whenever you take out the needle, there will be no oozing of the fluid from the peritoneal cavity over the surface of the abdomen. Now, what are the sites of the abdominal paracentesis? So one important site is 2 centimeters below the umbilicus in the midline. 2 centimeters below the umbilicus in the midline, over the linea alba. Over the linea alba. That is one place. Okay. But you need to take care of one important vessel over there, that is inferior epigastric artery. That is one site. The other important site is 4 centimeters supromedial to the anterior superior iliac spine. Okay, so here let us just assume this is the place where you have the anterior superior iliac spine, and 4 centimeters supromedial to the anterior superior iliac spine, you need to puncture and take out the fluid. And which side is preferred is, puncturing over the left side is being more preferred than puncturing over the right side. Why? Because over the right side, there is a high chance that you may puncture the viscera, you may puncture the gut. So to avoid that, you need to do the puncture 4 centimeters supromedial to the anterior superior iliac spine. And at that place, you will be also able to avoid the trauma to the inferior epigastric artery. Okay, so that is about the story related to the abdominal paracentesis. And what is the contraindication for abdominal paracentesis is, if there is presence of the coagulopathy, right? If there is presence of the coagulopathy, it is a relative contraindication to the abdominal paracentesis. So this completes the discussion of the ascites, various methods of detection, and what are the various types of the ascites, then examination findings, and finally treatment. right? The next topic which I'll do a quick revision is about the portal hypertension. So if you observe the normal pressure within the portal vein, right, the normal pressure within the portal vein, it is less than 5 millimeters of mercury, right? So this is less than 5 millimeters of mercury. What exactly is the definition of the portal hypertension? So the hepatic venous pressure gradient, okay, so the definition of the portal hypertension is if the hepatic venous pressure gradient if it is increased to more than 5 millimeters of mercury, right? The hepatic venous pressure gradient, if it has increased to more than 5 millimeters of mercury, then we use this term called as the portal hypertension, right? And one of the very important complications associated with the portal hypertension is the development of the esophageal varices, right? The development of the esophageal varices, okay? The esophageal varices, why there is esophageal varices? Because of the portosystemic anastomosis. The portal vein, it has the anastomosis with the esophageal vein, okay? So whenever there is portal hypertension, the pressure within the esophageal veins increases and that will result in esophageal varices, okay? And this esophageal varices will occur when the pressure within the esophageal veins, if it has increased to more than 12 millimeters of mercury, right? That is, so if the pressure within the portal vein, if it has increased to more than 12 millimeters of mercury, that will result in the development of the esophageal varices, right? And one of the very important cause for the development of the portal hypertension is the cirrhosis of liver, right? And what will be the earliest finding, right? What will be the earliest finding whenever there is development of the portal hypertension? That includes the splenomegaly, that is hypersplenism. Why there is splenomegaly? Because if you see how is this portal vein formed, the portal vein, it is being formed by the union of the splenic vein and superior mesenteric vein. So whenever there is increase in the pressure within the portal vein, the pressure within the portal vein will be exerted back onto the splenic vein, which will be exerted back onto the spleen, causing splenomegaly, right? So when the size of the spleen increases, this will contribute to the development of the hypersplenism. This will contribute to the development of the hypersplenism, okay? Now, not only that, if the pressure within the portal vein increases, the fluid from the portal vein will enter into the peritoneal cavity and that will result in the development of the ascites. That is another complication of the portal hypertension. And how is that you will be able to demonstrate the ascites? That is by your Puddle sign, shifting dullness, right? And as well as the fluid thrill, right? Then subsequently, now the three important places where you have the anastomosis of the portal vein is, portal vein is having anastomosis with the esophageal vein. So portal venous pressure, whenever it is increased, there will be esophageal varices. Whenever these esophageal varices rupture, the individual will have the hematemesis. And the other place where the portal vein has the anastomosis is with the umbilical veins, right? With the umbilical veins. So when the portal venous pressure is increased, the pressure within the umbilical veins will be increased and that will result in the development of the caput medusae, right? That will result in the development of the caput medusae, where there is dilatation of the veins surrounding the around the umbilicus. And the other place where you have anastomosis is the portal vein is having anastomosis with the superior and as well as the middle and inferior rectal veins. So whenever the portal venous pressure increases, the pressure is exerted over the rectal veins and that will result in the development of the rectal hemorrhoids, right? That will result in the development of the rectal hemorrhoids, okay? So these three are the important complications, important findings. One is esophageal varices, the second one is caput medusae, and third one is the rectal hemorrhoids, okay? And you need to be aware of what are the other abnormalities associated, the other complications associated with the portal hypertension. Apart from these, the other complications which are associated is the splenomegaly. as already I have discussed, the splenomegaly, whenever it is occurring, that can cause the rupture of the RBC, where the individual can develop the development of the anemia. And there will be also dilatation of the omental veins because of the anastomosis, right? It can also cause the dilatation of the retroperitoneal veins, right? And it can also cause the dilatation of the lumbar veins, right? It can also cause the dilatation of the lumbar veins. Okay, right. Now, what will be the complication of the esophageal varices we have discussed? That is the hematemesis, right? And the common cause of hematemesis with the splenomegaly, if the question is asked, common cause of hematemesis with the splenomegaly, what should be your answer? That is portal hypertension. Then how do you classify the etiology of the portal hypertension? We classify the etiology of the portal hypertension into three important divisions. One, it is the prehepatic causes for the portal hypertension, right? The prehepatic causes for the portal hypertension. Then the other one is the hepatic causes for the portal hypertension. Then the post-hepatic causes for the portal hypertension. Now, what are the prehepatic causes? The prehepatic causes for the portal hypertension include portal vein thrombosis, right? Portal vein thrombosis. And apart from that, we have a syndrome called Banty syndrome, or like that is also called as the Bantu syndrome. Now, what exactly is this Banty or Bantu syndrome? So, in these patients with the Banty syndrome, there will be massive splenomegaly because of the portal hypertension. And this Banty syndrome or the Bantu syndrome, it is there is iron overload. And why there is, and this is very common in the African countries. And this is due to consumption of the local beer which is stored in the iron utensils. That is what is your Bantu syndrome or the Banty syndrome, right? Then, what are the hepatic causes for the development of the portal hypertension? Like, we classify this again into the pre-sinusoidal. Then we have the sinusoidal causes. Then we have the post-sinusoidal causes, right? Then we have the post-sinusoidal causes. Pre-sinusoidal causes are schistosomiasis, right? Sinusoidal causes are cirrhosis of liver. And the post-sinusoidal causes are the radiation or veno-occlusive diseases, right? Veno-occlusive diseases. Okay, these are the hepatic causes. And what are the post-hepatic causes? The post-hepatic causes include the Budd-Chiari syndrome, right? Or the inferior vena cava webs, right? The inferior vena cava webs. Okay, and one more important condition, that is restrictive cardiomyopathy. So these are all the etiologies that will be causing the portal hypertension, right? Now, coming to the management or the treatment. First of all, what exactly is the investigation of choice for detecting the portal hypertension? That is by ultrasonography. And when you do an ultrasonography, you will find that the spleen is enlarged, portal venous pressure, it is increased, right? And if it is cirrhosis of liver, the liver span, if it is in the later stages, the liver span, it will be reduced. Okay, and there will be also presence of the free fluid within the peritoneal cavity, which is nothing but the ascites, right? And on the Doppler scan, which is nothing but the investigation of choice for diagnosis of the portal hypertension. So in the USG, like we have the Doppler scan. So Doppler scan is the investigation of choice for the diagnosis of the portal hypertension. And this Doppler scan is the one which will measure the pressure gradient, right? Doppler scan is the one which will measure the pressure gradient. That is the investigation of choice, right? Then followed by that, coming to the treatment. So if you observe the treatment for non-bleeding esophageal varices, what exactly is the treatment? Okay, for non-bleeding esophageal varices, what is that you need to do? We can give the drugs, that is beta blockers, example propranolol, right, or the another important molecule, that is the nadolol. Okay, so propranolol or nadolol should be given, right? And the other way by which you can treat is, you can also do esophageal variceal ligation. Esophageal variceal ligation. So how is that you will do esophageal variceal ligation? That is endoscopic, right? Endoscopic variceal ligation by endoscopic approach, right? Now, this is for non-bleeding esophageal varices, right? Whereas for bleeding esophageal varices, right? For bleeding esophageal varices, what is the treatment that you need to give is, the first line treatment will be, you need to give IV fluids. Why? Because the individual will be having the vascular collapse. Once there is a vascular collapse, you need to give the IV fluids, right? And then followed by that, you also need to give the blood transfusion after doing the cross matching within the patient, right? So blood transfusion should be done, okay? And the next important is, you need to give the drugs which will reduce the bleeding from that bleeding esophageal varices. And what will be the drug of choice? That includes the terlipressin, right? And the alternative drug will be somatostatin analog, right? The alternative will be somatostatin analog, that is octreotide, should be given, right? And once the individual is stabilized, then what will be the treatment of choice? The treatment of choice is, you need to do upper GI endoscopy, right? After doing the upper GI endoscopy, you need to plan for the same, that is esophageal variceal ligation or banding should be done, right? And the next important is, the other alternative is, you need to do the sclerotherapy, right? You need to do sclerotherapy. What is that sclerotherapy? Where you will inject the sclerosing agents. And what will be that sclerosing agents? The sclerosing agents include ethanolamine oleate, right? The sclerosing agent include ethanolamine oleate. That is what is your the sclerotherapy, right? So that is about the treatment. And if suppose, if the patient is having, right, if the patient is having recurrent variceal bleeding, right? If the patient is having recurrent variceal bleeding, then what are the various methods by which you can handle this recurrent variceal bleeding? One, you need to do what is called TIPS, right? That is transjugular intrahepatic portosystemic shunt, right? That is one method by which you can treat. And the other method is, you have to plan for the liver transplantation, okay? That is orthoptic liver transplantation. So this is the other way by which you can handle this recurrent esophageal varices and recurrent bleeding from the esophageal varices, okay, right? So the tips will be minimally invasive, and liver transplantation, definitely it is like more invasive procedure. So this is about your portal hypertension. The next important topic for the quick revision in the hepatobiliary system is viral hepatitis, where we need to discuss mainly about the hepatitis B and its serology and then its treatment. So among the viral hepatitis, like we have the hepatitis A, B, C, D and as well as E. And which is very important from the clinical point of view is the hepatitis B. And what is the modes of transmission of this, the hepatitis virus? Hepatitis A and as well as the hepatitis E. These two, the mode of transmission or the route of transmission is the fecal-oral route of transmission, right? Whereas you take the hepatitis B, C and as well as D. So hepatitis B, C and as well as D, the route of transmission is sexual transmission, then vertical transmission, right? Then parenteral transmission, right? The parenteral transmission. Okay, so these are the various routes by which the BCD transmission occurs, right? Now, followed by that, we will take up the detailed discussion related to the hepatitis B. So if you take this hepatitis B, you have acute viral hepatitis B and then chronic viral hepatitis B, right? So acute viral hepatitis is that where the individual will develop the fever, fatigue, and there can be even jaundice. And among these BCD, which is the most common virus which is associated with the transfusion, okay? So the other way by which is, yeah, your parenteral transmission is nothing but by the needle prick or even by transfusion also, blood transfusion. But the most common virus associated with transfusion associated hepatitis, the most common will be the hepatitis B virus, okay? And which is that virus, which viral hepatitis does not have the vaccine or the prophylaxis? The hepatitis C, there is no vaccine, right? Or even there is no prophylaxis for the hepatitis C. And which is that which virus is having highest malignant potential? Same. The malignant potential, it is, that is hepatocellular carcinoma, it is very high for hepatitis C, right? And what is that particular viruses which have the higher tendency for the chronicity? The higher tendency for chronicity is for hepatitis B and as well as the hepatitis C, right? Then, now routes of transmission I have already discussed, and please remember your hepatitis B, it is not transmitted through feco-oral route. It is not transmitted through the feco-oral route. And between your B and C also, if the question is asked, what is the most common hepatitis that will progress to chronicity? It will be hepatitis C. It will be hepatitis C. Then what is the most common cause of fulminant hepatitis in pregnant women? Right? Most common cause of the fulminant hepatitis in the pregnant women, that will be hepatitis E. Right? That will be hepatitis E. Right? And what is the most common cause of the sporadic hepatitis in children? Right? Most common cause of the sporadic hepatitis in children. The most common cause of the sporadic hepatitis in children, that will be hepatitis A, because it is like feco-oral route of the transmission, right? Now, let me take up the detailed discussion of your hepatitis B. So hepatitis B, like what are the various routes of transmission? That is percutaneous, right? Parenteral, right? Which is nothing but your percutaneous or needle prick, or the transfusion, sexual route of transmission, and then vertical transmission, that is from mother to fetus. Now, we have various other viruses by which we can, the transmission occurs by the needle prick, okay? So we have the hepatitis B, then we have the HIV, and then hepatitis C. But which particular virus has the highest transmission through the percutaneous route or the needle prick? That will be your hepatitis B. So the hepatitis B transmission, if you see through the needle prick, that is almost 30%. Whereas for HIV, it is just only 0.3%. Right? For HIV, it is only just 0.3%. Okay. Now, once the hepatitis B virus enters into the blood, what is the first important serological marker that will appear in the blood? So, the first important serological marker that will appear in the blood will be appearance of the HBsAg. right, the appearance of the HBsAg. This is the first important serological marker that will appear in the blood, right? Now, in case of the acute viral hepatitis, what will be the features, right? And what will be in the chronic, and what will be the serology, and then finally what will be the treatment is what we will be discussing now. Now, in case of acute viral hepatitis, these patients, they'll have fever, right? And on examination, they'll have the icterus, and icterus, you know where the icterus appears first? The icterus, it is not first observed over the sclera of the eye. The icterus, it is first observed over the frenulum of the tongue. It is first observed over the frenulum of the tongue. Okay. Then followed by that, the icterus or the yellowishness will appear within the sclera. Will appear in the sclera. And in acute viral hepatitis, when you examine the right hypochondrium, there is tenderness. Right? There will be tenderness in the right upper quadrant. Why? Because it is an inflamed liver and there is hepatomegaly. So, you will also observe that there is increased liver span. Right? You will also observe that there is increased liver span. Okay. And how much will be that? The normal liver span, it is around 12 to 15 centimeters. That is a normal liver span. And in patients with hepatomegaly, there will be like the liver span will be more than 15 centimeters, right? And when you do a workup in these individuals with acute viral hepatitis, because it is an acute viral hepatitis where there is an inflammation, so definitely the serum bilirubin will be elevated because you have the pathology within the liver, right? And that too, an unconjugated bilirubin will be increased. And along with that, the enzymes. Okay, what will be that enzymes? That is SGOT and as well as SGPT, both of them, they are elevated. Okay, so SGOT is increased and as well as the SGPT is also increased. But between these two, which is more increased? Remember, SGPT is more increased than compared to that of the SGOT, right? Whereas the condition where the SGOT is more increased than compared to that of the SGPT, this you will observe in the alcoholic liver disease. Right? This you will observe in the alcoholic liver disease. Okay, where SGOT is more than compared to that of the SGPT. Right? Whereas in viral hepatitis, the SGPT will be more than compared to that of the SGOT. Right? And what about the serum alkaline phosphatase levels? This will remain normal. What are the conditions where the serum alkaline phosphatase levels will be elevated? That is in obstructive jaundice, the serum alkaline phosphatase levels will be elevated. Then, when you do an ultrasound of the abdomen, in case of this viral hepatitis, if you observe the echo texture, right? If you observe the echo texture, you will have what is called as the appearance of the liver parenchyma will be in the form of a starry sky appearance. Starry sky appearance. And in the USG, you will also be able to notice that the liver span, it is increased. Right? Now, the starry sky appearance, there are multiple other conditions. Right? So, when you do a lymph node biopsy where you will have the starry sky appearance, that is in case of the Burkitt's lymphoma. Right? And kidney biopsy, when you do, where is that you will have the starry sky appearance is in the post-streptococcal glomerulonephritis. Whereas when you do a CT brain, where is that you will have the starry sky appearance is the neurocysticercosis. And when you do an ultrasound abdomen, where is that you will have a starry sky appearance over the liver parenchyma, that is in case of the viral hepatitis. Okay. So this is about the workup. Now, and in case of the treatment for acute viral hepatitis. See, the treatment for acute viral hepatitis, you need to understand that these patients with acute, they don't require the antiviral drugs. They don't require the antiviral drugs. So it is just only supportive treatment. Right? It is just only supportive treatment, but no antivirals. No antivirals, which is very important. Okay, so supportive treatment means what? Like the fever is there, you need to give the paracetamol, right? And if the individual is having fatigue, right, then some multivitamin supplementation can be given. So it is supportive treatment, but antivirals are not required in the acute viral hepatitis, right? And the next important part of the discussion will be the serology. Okay, now what is the first important serological marker that will appear? That is the HBsAg. But you need to understand that if the HBsAg is positive, can you tell that it is only acute viral hepatitis? No, right? The HBsAg, if it is positive, it can be an acute disease. If the HBsAg is positive, this can be a chronic disease, right? And if the HBsAg is positive, this can be even the carrier stage, right? This can be even the carrier stage. Okay, now followed by that, if anti-HBsAg is positive, right? If anti-HBsAg is positive, anti-HBsAg indicates the development of the immunity, right? Indicates the development of the immunity, right? So if anti-HBsAg is positive, that means the individual is immune, right? Or in this particular patient, the disease is cured, and that means that the individual is not having any active disease, right? The individual is not having any active disease. So that is what is your anti-HBsAg being positive, right? Then apart from this HBsAg and as well as the anti-HBsAg, the another important serological markers are IgM anti-HBc, right? IgM anti-HBc. Okay, so IgM anti-HBc, if it is present, it is suggestive of acute viral hepatitis. Now if the question is asked, what is the serological marker which will test your acute viral hepatitis, is if both the options are given, HBsAg and IgM anti-HBc is there, you should go for IgM anti-HBc. You should go for IgM anti-HBc, not HBsAg. Why? Because HBsAg definitely it's the first serological marker that will appear, but the HBsAg is not positive only in acute. It can be positive in chronic. It can be positive even in the carrier stage also, right? So, and the next important serological marker is IgG anti-HBc. IgG anti-HBc, if it is positive, that is suggestive of the chronic viral hepatitis. That is suggestive of chronic viral hepatitis. Then what is that viral hepatitis which will tell you about the infectivity, right? What is that viral hepatitis that will tell you about the infectivity? The infectivity can be demonstrated by the envelope antigen. If HBeAg is positive, that tells the individual is highly infective, right? Then apart from this HBeAg, you need to know the markers of the HBV replication. Right, the markers of the HBV replication. The markers of the HBV replication are HBeAg. HBeAg, this is a qualitative marker for, right? So this is a qualitative marker for the HBV replication, right? Then the other serological markers are the HBV DNA, right? Then followed by that, the DNA polymerase. Right, then followed by the DNA polymerase. So HBV DNA and as well as DNA polymerase, these two are the quantitative markers. Right, these two are the quantitative markers. Okay, but among these, which is the definite marker? The DNA polymerase, this is considered as the definite marker for the viral replication. This is considered as definite marker for viral replication. Okay, then followed by that, you take the recovery of acute hepatitis. Whenever there is recovery from acute hepatitis, and you need to understand that it is the acute viral hepatitis which will progress to chronic viral hepatitis. Now, what are the factors which will determine the progression of acute viral hepatitis to the chronic viral hepatitis? So, the factors that will determine the progression of acute to chronic, it is the immunity of the individual, right? If the immunity of the individual is good, then the acute viral hepatitis, it will get reverted. It will be like self-limited. But for suppose if the immunity is like compromised, for example, you take in children, the immunity has not yet developed, and if they develop acute viral hepatitis, there is a high scope that acute viral hepatitis will grow to chronic viral hepatitis in children. And second one is in elderly individuals. In elderly individuals, the immunity decreases. So in elderly individuals, if they develop acute viral hepatitis, there is a high chance that the acute will progress to the chronic viral hepatitis. Okay? But when this acute viral hepatitis is getting recovered, then what will be the markers? So the recovery of acute hepatitis, it is accompanied by, what did I tell you in acute hepatitis? The enzymes are elevated. SGOT and SGPT, they are elevated. So there will be normalization of, right, there will be normalization of the AST and as well as the ALT. Number 2, disappearance of disappearance of the HBV DNA levels, right? Next, the envelope antigen, that is HBeAg, will undergo the seroconversion to anti-HBeAg. Right? So there will be seroconversion of the HBeAg to anti-HBeAg, right? And not only that, the surface antigen HBsAg will undergo seroconversion to anti-HBsAg. Seroconversion will be there. Okay, so this is how, these are all the parameters which are telling you that there is recovery of the acute viral hepatitis, right? So the serological marker that is first to appear is HBsAg, right? Then, and you need to be aware of what is the serological marker that represents that the individual is in window period, right? What is the serological marker that will tell you the individual is in window period? That is IgM anti-HBc. So IgM anti-HBc, either it will tell you an acute hepatitis B, right? Or it will tell you that the individual is in the window period of the hepatitis B infection. And what is that which will tell you that the individual is vaccinated? So I was telling you about the anti-HBsAg, the serological marker in vaccinated individuals, that will tell you it is that the individual is immune. What is that? That is anti-HBsAg, right? Anti-HBsAg. Okay, so serology is very, very important part of the discussion or the questions in the hepatitis B virus. Okay, right. Then followed by that, let us discuss the treatment. Now, if you take the treatment for acute viral hepatitis, you don't require the antiviral drugs. It is just only the supportive treatment, right? The management, the antiviral drugs are required in case of the chronic hepatitis B. They are required in chronic hepatitis B. So, in chronic hepatitis B, you have the requirement of the antiviral drugs. Right? You have the requirement of the antiviral drugs. Okay. Now, so if you take the treatment for the chronic, what are these antiviral drugs? Actually, we have many antiviral drugs. That includes interferon, tenofovir, then, and interferon, what we give is pegylated interferon, then entecavir, telbuvidin, lamivudin. and even adifovir. These are all the antiviral drugs. But out of this, what are the first line antiviral drugs? That includes PET. And PET stands for the pegylated interferon, E stands for entecavir, and T stands for tenofovir. Right? T stands for T. These are the first line. So this pegylated interferon, it is given through subcutaneous route, whereas these two, they are given through the oral route. Now the question comes, do all the patients with chronic hepatitis B will require the antiviral drugs? No. The requirement of the antiviral drugs, it depends on two important things in case of the chronic hepatitis B. So in chronic hepatitis B, right, along with IgG anti-HBC being positive, if HBeAg levels are positive, if HBeAg is positive, what does that indicate? That indicates that the individual is highly infective, right? That is one point. And the second point is, you need to estimate the levels of the HBV DNA levels. Now, if suppose, if the HBV DNA levels, if they are elevated more than 20,000 copies, right, more than 20,000 DNA copies per ml. So remember, the nuclear material in all the viral hepatitis is actually RNA. You take A, you take C, D, E, it is RNA. But only for hepatitis B, the nuclear material is the DNA, right? So if the number of HBV DNA copies, if they are like more than 20,000 DNA copies per ml, and along with that, if the SGPT, right, along with that, if the SGPT, if it is elevated 2 times, right, if the SGPT is elevated 2 times, that is the indication of starting the antiviral drug, right? So what are the first line antiviral drugs? Either pegylated interferon or entecavir or tenofovir. What are the other drugs? The other drugs include the adifovir, lamivudine, and then telbivudine, right? So this is about the treatment of the chronic hepatitis B virus, and this completes the discussion of the viral hepatitis, right? So with this, we are done with a quick revision of the entire hepatobiliary system topics. Thank you very much.